politics as it relates to governance and as it relates to containing, controlling, adapting, and mitigating in relationship to an epidemic like Ebola. There are deep and important questions around equity, inequity, vulnerability, invulnerability. And many of our conceptions that drive our governance choices are deeply flawed and are flawed to the extent that they actually create a false sense of security for some and mask what in fact is global vulnerability. The second is that, I can't even read my own writing here. The second is that this calls really for a complete reconception of global health. And that this is, in my mind, really, again, yet another opportunity, which we may or may not take, I don't know. It's another opportunity to really reimagine this idea, this concept, this practice, this quasi-discipline, which we call global health. And in my view, if I can just leap forward to what, without going into any kind of analysis of what that might, analysis might look like, let me just say that I think that global health has to leap forward to a conception and a practice based in an idea of global public health. And global public health has to be an amalgam, a re-amalgam of both clinical medicine and population-based perspectives on human well-being. If we look at the history of public health emerged in the midst of the Industrial Revolution. It emerged among practitioners, people who were directly in relationship and in the doing, tangible, touching, physical relationship with others who were in some way vulnerable, in some way suffering, in some way diseased or in a state of non-well-being. That proximity has embedded in it deep knowledge that if you simply abstract that knowledge into a public health perspective and then divorce it from the relational dimension that created it, you actually create this kind of schizophrenia in terms of how you approach well-being. There is no population without individuals, and an individual cannot experience well-being unless his or her community or population is in a relative state of well-being. So I think this is a real challenge, and it is the right kind of challenge for an academic institution to really think about. The third area is this idea of interdependence. I think we actually have to go even further. We're not simply interdependent. The idea of interdependence suggests that there are discrete entities that in some way choose to relate, or that those relationships can be severed at will, or in the interests of state security, or in the interests of contagion control, and so on and so on. There is some truth to that. There is some element of possibility in terms of intervention. But what we have previously conceived of as interdependence, that we are discrete and yet we choose to relate, in fact, I think it's a limited, it's not a correct notion. We are not interdependent. We are actually indivisible. And we live in an indivisible global ecosphere and ethnosphere and political context that makes us completely indivisible. Now, the degree to which we understand that will very much influence the degree to which we're able to address the other prior issues. And then finally, I think the fourth kind of category is really, it's much more, even more abstract than the previous three that I've just described. it's about what is the nature of fear and what is the nature of trust. And what we have seen in this epidemic, and I've seen it many times in many different types of epidemics, what we've seen is that fear itself is a variable. And not only is it a variable, but it is shaped by the context in which that response emerges. And it becomes then not only a response, but it then becomes a causal variable itself. And so how one approaches not so much the elimination of fear, but the, I would say the avoidance or the minimization of fear, how one approaches that is deeply central to containing, controlling, mitigating, and adapting to the biological phenomenon of an epidemic like Ebola. And then trust, what we've seen here is a failure of trust at so many different levels. And for so many reasons, so many very good reasons. And we need to understand that. And so we see, for example, in July and August, or even earlier, in fact, April, May, we saw the rapid prevalence and spread of rumors that, in fact, Ebola was a virus propagated by first the CIA, then former Russian intelligence, then the pharmaceutical industry, and so on. All of these very, very real rumors. Now, you can dismiss them, but you do so at your peril, because the fact is that people believe them, and they believe them for a reason. And then again, one can also look at the emergence of the mistrust of the pharmaceutical industry. This became a huge variable in terms of whether or not people would listen and respond to public health interventions by healthcare professionals. And then the link between these two these two variables, and then the medical professionals themselves, that they are part of this system, and that civil society organizations like Médecins Sans Frontières are actually part of this conspiracy, are actually part of this worldview that minimizes the meaning and the value and so on of people in West Africa. These are very real phenomena. And then you can also look at the mistrust of government. Why did people not trust their government? Should they trust their government? What prior experiences, what prior events have led to this profound mistrust? And is this a phenomenon that is unique to West Africa? Well, guess what? No, it's not. Right? So understanding these variables are extremely important in terms of what kind of lessons we choose to learn from the opportunity that's before us. And I'll stop there.
Can people hear me okay at the back? Good. Just before I start, is there anybody in the room that's actually been to West Africa and is back, that's kind of lurking in there, that has the real life experience that might want to come and sit up front with us? They don't have to come and sit up front with us if they don't want to, but if you've been there working, let me just give my thanks to you, and I think we should all acknowledge that, so our gratitude. So those who know me know that I started out in philosophy, so I'm going to put mine through a philosophical lens by utilizing great philosophers. The first one, Yogi Berra. It ain't over till it's over, and in fact, it's never over. We seem to believe that we can if we bring the Ebola outbreak to an end, we've somehow brought it to an end. But it actually won't be over if, in fact, we don't make significant investment into public health and clinical infrastructure there. To me, it would be a huge mistake if we've now got multiple epidemiological teams on the ground doing contact tracing. We've got clinical pipelines for clinical trials open. In fact, the first few clinical trials for antivirals and convalescent plasma have already started. Phase 3 vaccine trials will likely start sometime in February. And if all of that goes into place, and we've got treatment centers sprouting up all over the place, if all of that goes into place and then disappears, then we've left undisturbed the set of conditions that created the problem in the first place, which I'll allude to in my third point. The second piece of philosophy is collective philosophy. Excuse my language, shit happens, and we ought not to be surprised when it does. But it seems like, we're forever putting our fork in the socket and rediscovering outbreaks. But it's really not about the virus. And what's really remarkable about this outbreak in particular, setting aside the suffering of the people and the death and the morbidity and the mortality, is the massive destructiveness it's wrought along multiple lines. Within nation states, within communities, it's left economies in shatters. It's left the WHO questioning its legitimacy and its role. It's torn apart humanitarian organizations that I know of, about issues around standard of care, about the relationship between humanitarian medicine and public health, about the legitimate, who does the contact tracing, who does the isolation, who enforces isolation and quarantine in a context where there's no functioning public health law. There is a law, actually. Liberia and Sierra Leone and Guinea all have public health laws that stipulate for the control of communicable disease, but there's actually nothing there to make it happen. So yes, it's true. This is something that ought not to have happened at all. And if you look at the history of Ebola outbreaks, they've all been contained in low and middle income countries and under-resourced areas where cases have been identified, contact tracing has been 100%, and isolation of cases and appropriate management has taken place. So the game changer here was, as I said, stuff happens. It's kind of, again, great philosophers, Monty Python's, nobody expects the Spanish Inquisition. Nobody expected Ebola virus in West Africa. It was out of its range. But the one thing we should know after a decade, and I see Richard sitting right there, after SARS, after H1N1, after MERS, we ought to be expecting these things, picking up on David's initial point, and we ought not to be collectively going, oh my God, how can this possibly happen? I'm not that old. Really, I might look it these days, but this is like the 4th or 5th time this has happened in my I guess it's a longer career than I thought, and the reaction has been the same all the time. Do I have an obligation to care for people? Should we use public health measures? How do we settle out resource allocation? What's the global governance challenges? And so it's deja vu all over again, to quote my other favorite philosopher, Yogi Berra again. So the third thing is that, and what I'm hoping we can do here, is actually start the conversation to have, how many of you are students in public health?